Hello, everybody, and welcome to today's webinar. Today's webinar is CMS Proposed Physician Fee Schedule Rule for 2022 and the potential impact that it will have on your business. Nara is very excited to have our two presenters here today. We have Leigh from Care Navigation Consulting, and she is the president. We also have Mark McDavid, who is the president of Seagrove Rehab Partners. My name is Sabrina McCarley, and I will be the moderator for today's webinar. Before I turn it over to Leanne and Mark, I'd like to cover a few housekeeping rules. Just as a reminder, all attendees are on mute. We will be providing a copy of these slides with the recording in about 24 to 48 hours after today's webinar. We are going to have the flow of the presentation be Leanne and Mark are going to cover their slides. And then we're going to ask that if you have any questions for our speakers, that you type them into the Q&A and we will address those at the end of the presentation. If you have any technical questions, if you could please type those into the chat box, and Christy will be monitoring that. The session is being recorded, as I mentioned, and it will be emailed to all registered attendees in about 48 hours after our presentation today with the handouts. It will also be posted on our Nara member portal within 24 hours. And with that, Leanne, I'm going to turn it over to you.
All right. Thank you, Sabrina. And thank you, Nara and Sabrina and Christy for the opportunity here, and Mark for coming along and allowing me to be a part of this. So what we're going to cover today is not the full 800 plus pages, but the highlights, if you will, in regards to the physician fee schedule proposed rule. And so we'll start out talking about payment and the conversion factor, as well as the evaluation and management codes and the impact that continues to have on the conversion factor and the payment. We'll touch on MIPS, won't get into great detail in regards to that, focusing then on the telehealth and remote patient monitoring, at which point that will be turned over to Mark. And we'll discuss the assistant supervision in private practice, and probably spend a good bit of time on the assistant payment reduction, talking through some of the examples, and then hit a request from CMS on some feedback related to health equity. And we always want to talk about advocacy. So those are our objectives and topics for today. So as we start with payment, and we start with the conversion factor, again, we know that that number is the number, the multiplier that Medicare uses to apply to the RVUs in order to get the reimbursement for each of the codes in the physician fee schedule. So for this year, the proposed conversion factor dollar amount is $33.58, and that is down from calendar year 2021's $34.89. We thought it was important to put here kind of the trending, as you can see, from 2020 to 2021, and now with the proposed 2022 conversion factor of 33.58, the trending is not going in the right direction. We are trending downward. So we've included the formula for obviously the RVU calculations, understanding that the conversion factor, again, is the dollar amount that gives us those reimbursement numbers. So as we look at kind of what impacts this on the next slide, we all remember MACRA, the Medicare Access and CHIP Reauthorization Act that happened in 2015. That actually froze essentially the physician fee screen increases through 2024. It didn't freeze the decreases, but it froze any increases. In addition to that aspect, we have the expiration of the 3.75% infusion or increase, which was that $3 billion amount that was infused into the physician fee schedule last year from the Consolidated Appropriations Act, and that has expired. And then we always have to deal with the budget neutrality adjustments related to anything that changes RVUs, specific to this rule, the practice expense. And so whenever anything goes up, there has to be some decreases in order to maintain that budget neutrality. So the overall estimated impact for therapy is approximately a negative 4%. Now, the AMA actually did some discipline-specific assessments and analysis in and around the impact, and they came up with 3.9% for OT, 3.5% reduction for PT, and 3.8% for speech. But pointing out that if you have looked at the rule, there's a table 123, which initially we were led to believe was the overall impact of the rule, which showed a negative 2% for therapy. That is absolutely not the case. It's going to be somewhere around 3.5% to 4%. So as we look at the evaluation and management codes, if you remember last year, physicians were set to get some significant increases in these codes. And the impact of that from a therapy perspective was going to be quite significant. We were looking at about a 9% reduction last year. The Consolidated Appropriations Act reduced that by about 3%. And then they also put a moratorium on one of the new E&M codes, the G2211, which reduced the impact last year by another 3%. So our impact last year was not as significant as we had expected. Interestingly, in the proposed rule this year, there's little discussion about the E&M codes, but we do know that that moratorium goes through 2023. And that G2211 code is an add-on code that physicians can use. And so obviously it will be used, and there's a significant dollar amount attached to that. So we just need to remember and keep in the back of our mind that when that moratorium goes away, our physician fee screen again will get impacted, because that will cause an increase, which means somebody's codes are going to have to be decreased. And we expect that we may be a part of that. So again, just kind of keeping that in the back of our mind. So as we talked and alluded to MACRA in 2015, that led to the quality payment program, and it gave two pathways to get some increased dollars, or to capture that carrot, if you will. One was MIPS, the merit-based incentive payment system, and the other was the alternative payment model, or advanced alternative payment model. So we know that MIPS has been in transition from 2017 to 2021, as we've stepped up the performance threshold each year. This coming year, 2022, we're kind of at the point where it's now, we've taken the training wheels off, if you will. And even in the final, or in the proposed rule, CMS states they're going to be fulfilling that statutory requirement, which says that the performance threshold is either at the mean or the median of the final scores for all MIPS. So they expect 50% of the folks will get a bonus, and 50% will get a penalty. So again, the training wheels are off. A point to remind ourselves is institutional providers still excluded due to the requirement for us to bill on the institutional forms. So from an advocacy perspective, we need to keep that in mind. As the highlights of the MIPS proposal for 2022, they have increased that performance threshold to 75 points, up from 60. They've extended the exceptional performance bonus at 89 points, and they're estimating that the potential bonus is going to actually exceed the goal of 10%. These are actuaries who are estimating this, with the potential somewhere possibly hitting 14%. From some of the bonus points, though, have been removed going into the proposal for 2022, the high priority measures, the end-to-end bonus, and the data completeness points. So there's a potential for a 30-point negative impact there, if those are points that you've gotten historically. But there have been some bonus points that have been renewed rather. The bonus points related to the complex patients, those related to small practice, and quality improvement. So you still have an opportunity there for approximately 26 bonus points as it relates to those aspects. So again, Congress actually could extend the exceptional performance again, but they have certainly proposed to extend it for 2022. So everything else kind of remains the same. The data completeness is still at 70%. And with that, I'm going to turn it over to Mr. McDavid, and he's going to talk to us a little bit about telehealth.
All right, Leanne, so far bringing all the good news.
Yeah,
so thanks for that.
You're welcome.
All right, we're going to move on to something that hopefully has, there's a bit of silver lining here, and then we're going to revert back to some challenges. So telehealth, as you all know, we have had access to telehealth through the interim final rule as it relates to the public health emergency that is still in effect. We're thankful for that. If you remember when the telehealth became a thing for therapy last year, there were lots of questions and lots of issues that immediately came up. Who can do it? Where can we do it? When can we do it? What codes can we bill? What codes can't we bill? You know, all of those questions. And CMS was very generous through the office hours calls that they did, allowing us on the provider side to really ask the in the weeds questions that they honestly didn't have time, I don't think, to really kind of flesh out before allowing the expansion of telehealth and other types of distance treatment. And now we've got a little better thought out process. I know many of you have used telehealth in your practice, whether that's outpatient or institutional based, acute, whatever the case may be. I know we're seeing it in a lot of places. With a lot of success. And so we were delighted to see in the proposed rule that telehealth is included to some degree in the proposed rule. There's really two sides to this discussion: the code issue, do we have codes that we can bill? And the provider issue, or the eligible provider issue, I guess. So first, let's touch on the codes. CMS, you may recall, created Category 3, the Category 3 list, initially for the interim final rule. And at that time, we had many of the therapy codes added to that. There were some exclusions, but most of our codes were there. What they've proposed in this rule is to extend that Category 3 list through the end of 2023. So that temporary list will extend at least through the end of 2023. CMS did not propose, notably, to add the therapy codes to the Category 1 or Category 2 list of approved telehealth codes. That's important because Category 1 and 2 are the permanent lists. Those are the ones that that were existing before the interim final rule and the public health emergency. So CMS continues to seek additional information on where these codes should be and how they should be laid out and what should be included. And so from an advocacy standpoint, we will want to make sure to continue to talk about that. Next slide, Christy. The other piece are the clinician side, or the provider side. So even though we might have codes to bill, the question is, are we eligible providers? Well, we're not, and we continue to not be outside of the public health emergency. And so we need to make sure that after the expiration of the end of the year when the PHE expires, that we should continue to be added or continue to be part of the eligible provider list. And so that's another piece of advocacy as we go forward. Remote therapeutic monitoring or remote physiological monitoring are things that you may have heard some information about. And remote therapeutic monitoring codes were created. You can see I've listed those there for practitioners who are not eligible to bill remote physiological monitoring, but are services of a similar nature. So, you know, remote physiological monitoring are the E&M codes that physicians and PAs bill for providing that distance supervision, distance monitoring of a patient. And remote therapeutic monitoring was created for those folks who are not eligible to provide the RPM codes, such as, next slide, please, such as therapists. The RTM codes are used to monitor health conditions using FDA-approved medical devices, and CMS discovered that RTM codes are incident to codes. It's funny that this is the language that you see being talked about in the industry. CMS discovered that something occurred. CMS discovered that RTM codes were incident to. It's in their own regulations. How did they discover it? It's like there. So anyway, it's just kind of fun. Of course, This makes them unavailable because they're incident to. This makes them unavailable to therapists, even though they were designed and created to be used by folks like therapists. So CMS is again seeking additional input on how to resolve this issue and make it make all the pieces work together. And we'll talk about that in our advocacy piece a little bit here in a bit. Also, as you know, just a plug for Nara. Nara is putting together the comment letter. It's almost ready to go, and we've talked about all of these pieces in our comment letter as well. Assistant supervision in private practice. Again, part of the public health emergency was that CMS allowed for direct supervision to be provided via audiovisual technology through the end of the calendar year of the expiration of the public health emergency. So we're still in that PHE, and we're still benefiting, I guess, from that distance supervision, being able to do that via technology. The proposed rule discusses making this policy permanent. So if that's something that you're interested in, that may be a possibility here in the future. And CMS is seeking comment if this flexibility should be permanent or not. They also are indicating, also kind of related to that, pros and cons, other issues, I guess. Obviously, this would make supervision in the private practice space a bit easier if you didn't have to have that therapist on site when your assistant is treating. That may impact some of you out there who are currently rehab agencies. It may make you think that rehab agency designation. There are multiple moving parts when you make that decision, private practice versus rehab agency. One of those is the supervision piece. In the rehab agency space, that supervision is not a direct requirement. It's a general supervision. And so you can do that usually from a distance, whereas the private practice setting requirement is that on-site or direct supervision. So this may make some of you, or may impact some of you that are thinking about rehab agency, not rehab agency, private practice, which way we're going to go. The other piece we need to be aware of is anytime Medicare makes a federal change in regulation or rule, how do the states respond? So some of you may be operating in states that even though the private practice requirement changes at the federal level, you may have some state practice acts that speak to this and would be overarching over that requirement and saying, no, you still got to have that direct on site. So make sure that you're paying attention to your practice acts. So assistant payment reduction. This is probably why most of you are here. And as you walk down this slide, we are going to go from the 10,000 foot level to knee high on a snake as we get into the weeds. So Section 53107 of the Bipartisan Budget Act of 2018 is what put the assistant payment reduction out there. This is also where we started seeing, or where the repeal or the elimination of the therapy cap came from. And this is part of the pay for of the therapy cap repeal from a number of years ago. See, advocacy works. It didn't quite work like we wanted it to, but it worked. So what we're talking about is a 15% reduction in the payment for services provided by the therapy assistant. This applies to the 80% that Medicare covers, not the entire 100% of the fee schedule. So the 15% reduction applies to the 80%. The remaining 20% is not affected at this time. So ultimately, it's a 12% reduction in fee schedule for the therapy assistant services provided. We're talking about the CO and the CQ modifiers. You should be well aware of what those are and when they apply at this point, or when you are applying them at this point, because we should be doing that in our current practice. The de minimis standard is something that Medicare talks about in this proposed rule and has adopted, and we're going to touch on that. And then remaining units or remaining minutes, as I was reading through this and trying to prepare for this presentation, in the back of my mind, 8-minute rule, 8-minute rule, 8-minute rule is going off, because these are all Part B payments, right? And then we start talking about counting individual minutes. And so as we get into the weeds here in the next several slides, what I want you to remember is we're going to talk about counting minutes, but we're billing units. And we're going to talk about disregarding some minutes, but we're still only billing units. So it's not that we don't bill for certain minutes. It's this, they just don't make it into the unit calculation. So as we talk about the next several slides, and as we talk about this over the next several months, think about, we're billing units. And so we may disregard some minutes, but that means that we still need to bill them. The therapist still needs to code them in their billing, even though some of those minutes may not actually make it into a unit. So let's talk about the de minimis standard. The services are considered to be have been furnished in whole or in part when more than 10% of the services is furnished by the assistant. This applies to each 15-minute unit. This is new in the proposed rule. Previously, in whole or in part is what we had heard from Medicare. And they came up with the de minimis standard and said we could apply it to each 15-minute unit. So it's not the whole visit. It's not the 45 or 60-minute visit that's whole or part. It's each unit. Services provided by the assistant in conjunction with the therapist are considered to be provided by a therapist, and the CO/CQ does not apply. There should be an asterisk there, and really an asterisk on the next several slides, because we're going to talk about what Medicare says in the rule, and then we're going to talk about the exceptions to what Medicare says in the rule. So I'm going to say some things over the next few slides that you're going to be like, I don't think what he said was right. And partially it may not be until we get to the exceptions. So, hold your questions, hold your thoughts on that for just a few minutes, and let's talk about kind of how we walk through this. Medicare laid out some steps for determining when the CO and CQ modifiers apply. Before we get to step one, first thing you need to do when you look at a treatment session of 30, 40, 52, 73, 18 minutes is determine how many units are we talking about. That's number one. Based on the 8-minute rule, how many units do we get to bill? And then let's go to step one. So we want to identify the timed codes furnished for 15 minutes or more when any time code services were provided by the PTA or OTA that is in full 15-minute increments. The CO or CQ modifier applies. That makes a ton of sense. That's pretty straightforward. If the PTA, OTA provided the service, it was a full 15-minute unit, the CO, CQ applies. Pretty straightforward. Next slide, please. Step two is identify the services in which the therapist and assistant provided minutes of the same code. This includes, quote, remaining minutes in step one above a 15-minute unit. Determine if the de minimis standard has been exceeded. If so, apply the CO or CQ modifier. All right, now we start to get into the weeds a little bit. And so it's going to take a little bit of thinking. When we start talking about numbers of therapy minutes being provided, and then we convert that to units, as you know, we use a 15-minute unit as the unit. And so now Medicare has always told us how to come up with that number. And now we're starting to break that down and kind of go backwards a little bit. So if we provided 20 minutes of 97110, then we would have one 15-minute unit and 5 extra minutes. That's the way this is kind of talked about in the next several slides and what they talk about in the proposed rule. The de minimis standard says that if we provide at least 10, if the assistant provides at least 10% of the service of that unit, then you have met or exceeded the de minimis standard, and you should apply the CO or CQ. Again, there are some exceptions. The easiest way in my mind to do that, there are a couple of different ways that Medicare lays out in the proposed rule on how to come up with your 10%. But basically, you take the overall minutes of that treatment session, you divide by 10, i.e. 10%. You round to the nearest whole number. So go up or down based on 1.3 minutes or 1.8 minutes goes down to 1 or up to 2. And then you add a minute. So we end up at 2 or 3 minutes. And if the assistant provided more than that number, then you've exceeded the de minimis standard and the modifier should apply. I realize that's a little complicated. Looks like Leanne popped in, kind of like the angel from above. Leanne has words of wisdom. Leanne.
No, I just want to clarify because you said treatment session. So I just want to clarify we're talking about a unit.
Thank you. Yes,
Yep.
She is correct. We are talking about individual units. The angel from above. All right, moving on. Christy, next slide, please. Identify services in which, so step 3, identify services in which the therapist and assistant provided minutes of differing codes. Now, think about PT, PTA, both provided service to this patient. This one provided 97110. This one provided 97116. That's what we're talking about here. After applying step 1 for each service, compare the remaining minutes furnished by the PT or OT for one service with the remaining minutes furnished by the PTA or OTA of a differing service. Apply the CQ if the assistant minutes are greater than the therapy minutes. Do not apply the COCQ if the therapist minutes are greater than the assistant minutes. That's a whole lot of word salad. We're going to unpack that in just a few minutes. Next slide, please. Step 4, identify the different services in which the therapist and assistant each independently provided the same number of minutes. Once step 1 is completed for each service and remaining minutes of differing services provided by a therapist and assistant are the same, choose which service to bill, not both, and apply the CO or CQ if the assistant services were billed. That's a lot of words to say. If we both did 11 minutes, OT and the OTA, then we, the provider, get to decide, and 11 and 11 gets us 22 minutes. So we're at 1 unit, right? So we only get to bill 1 unit. Do we apply the CO or CQ? I did 97535. The OTA did 97530. Which one are we going to bill? I, the provider, get to decide which one we bill. If we bill the OTA's service, we apply the modifier and we take the reduction. If we bill the therapist service, we don't apply the modifier and we don't take the reduction. A little bit of strategery coming in here. All right, moving on, Christy. All right, for the remaining minutes, when we have extra minutes, in general, if the assistant provided 8 or more minutes and the therapist provided 8 or less than 8 minutes, or when both assistant and therapist provided less than 8 minutes of the same service, the modifier applies. So let's look at one of the tables, table 19. This is from the rule. They gave us a couple of scenarios. Scenario 1, you've got PT did 6 minutes, PTA did 8 minutes, total of 14 minutes. We get 1 unit, right? The PTA provided 8 or more minutes in this case, and the PT provided less than 8 minutes. So in this case, the de minimis standard applies, and we apply the modifier. Let me walk through the de minimis standard here in this example. So 14 minutes, divide by 10, you get 1.4 minutes. You round to the nearest integer, you end up at 1 minute. You add a minute, so now we're at 2 minutes. If the assistant provided more than 2 minutes in this scenario, then the de minimis standard is exceeded and the modifier applies. So that holds true in this example. In scenario 2, PT does 5 minutes, PTA does 5 minutes, total of 10 minutes. Again, 8 to 22 is 1 unit. So both PT and OT, both the PT and the PTA provided less than 8 minutes. If the de minimis standard is exceeded, it is in this case, then the modifier applies. All right, next slide, please. Conversely, the modifier would not apply when the therapist provides 8 or more minutes and the assistant provides less than 8 minutes of a timed code. Medicare agrees that if the therapist supply enough minutes to bill on their own for service provided, then the modifier should not apply. Jump to table 20. So this is the next table in the rule, but in the language in the rule, it's 800 and some odd pages. About 700 pages of that is Medicare telling us about the history of how we got here for each section that they talk about. And in the history of the comments that how we got here, Medicare talked about in this section how stakeholders mentioned this was if we had to apply the modifier in this case, where if the therapist did 8 or more minutes and the assistant did 4, 5, 6 minutes, we've exceeded the de minimis standard, but we didn't need the assistant minutes to actually achieve the unit. And so this would be a disincentive to have to provide more service to the patient, because we're going to get a smaller reimbursement. And so that's what Medicare has done here, is taken into account that situation and that exception really, and said if the PT provides 8 minutes, PTA provides 7 minutes, total of 15 minutes, then how do we handle that? The PT provided enough minutes of service to get the unit. So we disregard from a billing standpoint the PTA's minutes and we still bill 1 unit. Disregarding their minutes does not mean we don't put them on the bill. In the software. The therapists still need to bill for what they did, and the software has to figure all this out, right? And that's part of our advocacy problem that we're going to touch on here in a minute. Scenario 2, back up one, Christy. Scenario 2 there is 11 minutes and 11 minutes. Same scenario. We had the therapist build enough minutes to achieve the 1 unit. And again, we're only at 1 unit because it's 22 minutes. So we only get to build 1 unit. Therapist did enough to achieve that 1 unit. The remaining minutes in this case is another 11 minutes, but it doesn't get us to the next unit. So we don't have to worry about that. So we, again, disregard from a unit standpoint, the assistant minutes, and we do not apply the modifier. Okay, next one. All right, so I took the examples directly from the proposed rule because this is so far in the weeds that I'm sure I would have gotten it wrong if Leanne and I tried to make up our own. And I also gave you an image here of a dude running an abacus because I think we're going to need an abacus to figure all this out. As I was going through putting this together, and Leanne and I were talking about it, I thought back to, it was 2010, 11, 12, when we went to MDS3, and then we converted and started counting group minutes, and we had the 25% limitation on group. And I don't know if you remember, but as you started doing more group in that scenario, you actually got to bill for more group, but you had to discount part of it. And so the numbers got all kind of squirrely, and you needed a calculator and an abacus and an Excel spreadsheet to figure it all out. I kind of feel like that's where we are right now. So I hope our software friends are good at this. So example A, this starts on page about 286 of the proposed rule. If you want to go see the examples and more explanation for each of these examples, 286 of the proposed rule. So in this example, PTA did 10 minutes of 110, PT did 5 minutes of 110. We have a total 15 minutes. It's 1 unit, right? Pretty straightforward. This one I think is pretty easy. We build 1 unit, we add the modifier because the PTA provided 8 minutes or more and the PT provided less than 8 minutes. Pretty straightforward. Next slide. Example B, PTA provides 5 minutes, PT provides 6 minutes, both of 110, total of 11 minutes. We end up with 1 unit, right? We get to build 1 unit. In this case, we build the CQ modifier because the PTA and PT both provided less than 8 minutes, and we needed both of their input to get to the 8-minute threshold. So the de minimis standard applies, and we apply the modifier. Example C gets a little more complicated. Still same discipline. PT and PTA both provide 110. And for a total of 45 minutes. So now we're adding up our units, right? 45 minutes based on the 8-minute rule gets us 3 units. So how do we break up a 22 and a 23-minute situation? This is where our remaining minutes come into play. So for step 1 in our steps above, we apply, PTA did 15 minutes on their own, and that unit gets a CQ, and they have 7 minutes remaining. Step 1 applies to the PT's 23 minutes, which results in 15 minutes of 110 and 8 minutes remaining. So you compare the remaining minutes and apply the CQ modifier according to the tables that we looked at. PT 8 minutes, PTA 7 minutes. In this case, no modifier because the PT achieved the next unit on their own. And we didn't need that extra 7 minutes from the PTA in order to get to the 8-minute threshold. Next slide. Example D is 14 minutes PTA of 110, 12 minutes PT of 110, and then we're adding in a different code, 20 minutes of 140. So again, we're at 3 units or 46 minutes. And how do we break that down? We build 1 unit of 140 with no CQ. That was all the PT. PTA didn't do any of that. So that's all PT, and we have 5 remaining minutes of PT. And then we have to deal with 2 units of 110 and how we break that up. 14 and 12 gets us 24 minutes. And so we build 1 unit with the CQ and the remaining 5 minutes and 1 unit without because they each did at least 8 minutes on their own. And the remaining 5 minutes of 140 doesn't get billed in a unit. It still, again, makes it onto your billing. It still makes the therapist still records those minutes. It just doesn't get make it over to the claim in a minute form. Christy? Example E, we're going to switch disciplines on you. OTA provides 11 minutes of 535. OT provides 11 minutes of 530. Total of 22 minutes. We end up with 1 unit because we're 8 to 22. This is a tiebreaker scenario that is described in the Medicare Claims Processing Manual. This was described in the previous rule, but Chapter 5 of the Claims Processing Manual, Section 20.2, you can see that rule. I'm sorry, that scenario. In this case, you get to choose which one of these you bill. If you had more minutes on one than the other, then that's the one you would do, right? If we had 12 minutes OTA of 535, well, that would put us into 2 units. Let's go 10 and 10. If we had 10 and 10, then we're in the same scenario. If we went 11 and 10 and the OTA did 11 minutes, then we have to bill the OTA's unit versus the OTs. But because we have the same number of minutes, then we get a choice. We get to bill either service, applying the CO modifier only if we bill the OTA's service. Again, it's only 1 unit, so we get to bill one of them. If you choose to bill the OT service, then you wouldn't have to apply the modifier and you would not take the reduction. Again, a little bit of strategery here. Christy? All right, example F is for untimed codes. The OTA 20 minutes of 97150 and 20 minutes of OT for 971, that should say 97150. So total of 40 minutes in group. The de minimis standard applies here, and they bill the 97150 with the CO modifier. This one, I'm gonna be honest with you, I didn't fully understand. And as I dug into it, I didn't really get a good answer from what's in the rule. And so there's a little more exploration to do on understanding how they came up with the CO in this example, because it's a 1 unit. Anyway, so we'll come back to that. All right, next slide, Christy. So we've been in the weeds, and there are obviously, again, you need an abacus, an Excel spreadsheet, and a calculator to figure this stuff out. And so there's some concerns with where we are. And these are some of the concerns that Nara has put in our comment letter. Obviously, the full units, pretty straightforward. When we start getting into parts of units or remaining minutes, that's where we get in the weeds. So concerns are, can the software vendors code this in 30 or 60 days once we know when the final rule comes out? Also, I heard Jerry over at Clinician talking about this the other day. Nancy and Jerry did a webinar, and some other young lady whose name I'm not calling at the moment, and which was great, by the way. If you haven't seen that, I would encourage you to. But Jerry talked about the concern over the MACs being able to accept 2 lines on the claim of the same CPT code, one with a modifier and one without. So one of the concerns, one additional concern I think that we have is, do the MACs have time to get their software, one, set up and done and completed, and then turn around and tested before we actually have to start using this stuff on January 1st? Our angel has returned. Yes, ma'am.
Thank you, Mark. Just a couple of thoughts as you and I spoke in preparation for this. One is, what we don't need to happen is folks to try to avoid extra minutes or remaining minutes.
That's right.
We don't need to focus on, just 15 or 30 or so on and so forth. So we just really wanted to make that clear. I think the other piece of this is, as Mark and I were going through the examples, it really is a flow chart, right? So we got to take the total minutes, because we're constrained for the number of units we bill by the total minutes. How many units do we have? Then obviously step 1, where did we get 15? That's a no-brainer. Parse those out, right? And then when there are remaining minutes, did the therapist have 8 minutes? Then we know we have a unit there. Where they didn't, then you got to start to kind of do the math.
Yeah, as Leanne and I talked about it, and I'm sure y'all have seen the RAI flow charts before. How did you come up with the ADL score? right? And how did we, there's several of those in the REI manual. I was like, that's what we need. We need one of those flow charts for how do we come up with assistant reduction in payment, or COCQ. And so maybe that's what we ask for. I don't know.
I think the other piece of it, Mark, is while they didn't imply a documentation or apply a documentation requirement, they were very clear in regards to the expectation that they should be able to discern, right, who is involved in those pieces within the documentation. So while it's not a required, field or specificity, if you will, there is an expectation that when you read the note, you should be able to discern there were two folks involved of different. In
the proposed rule, where they were using some language from previous rules, and they had brought up documentation requirements surrounding this issue. There were a lot of stakeholders who were like, look, Paperwork Reduction Act and provider burden and all of these other things don't make us document something else. And so they basically acquiesced on the documentation requirement, but they did, to Leanne's point, make it clear that they should be able to discern who did what. I think the service log is going to come into play there for sure to show who did what, but also some narrative note, as we're figuring all this stuff out. So to Leanne's other point on not rounding to the full unit, right? Our team just did an IRO for a group, and one of the things we were looking at was their daily billing. Were they rounding? Were they not? Because that's something that needed to be addressed for the IRO requirements. So, make sure that you're not asking your therapist to round to a 5 or a 0 or to a full unit. They need to bill for what they did. And we're going to figure out via software what that turns into units. All right. With that, Leanne, I will bow out and pass it over to you.
All right, thank you, sir. I'm going to add to the Q&A. How do you get knee high on a snake? But we'll save that one for later. Yeah. You have an answer?
For later.
Okay, all right. So health equity. Again, one of the things that COVID-19 and the PHE has certainly highlighted is a gap as it relates to health equity. And so we found it important enough to put in this presentation that CMS is looking for stakeholder feedback. They're looking to create a more comprehensive request for information focused on closing the health equity gap as it relates to CMS programs and policies and so on and so forth. So, they are asking for any input as it relates to reporting health disparities based on social risk factors, race, ethnicity, etc. Now, in the proposed rule, they reference this as it relates to stratification of quality measures, and how can they identify and provide us as providers with some data that would help us identify these gaps and work to improve them without impacting the individual's privacy and so on and so forth. So it's really a matter of, have you seen within your practice or your organization any of these gaps or identified any information that would be helpful for you as a provider to get from CMS, delineated by, again, whether it's race, ethnicity, so on and so forth, that would help you to work on obtaining more health equity. So that is part of the proposed rule. So wanted to bring that to your attention so that we could provide comments in and around that as well. Next slide, Christy. And we always have to talk about advocacy. So hopefully why advocacy isn't something we have to answer per se, but we thought that the slide that demonstrates what we have dealt with, if you will, throughout the last 10 years and ongoing, one by one, they're significant. But when you look at the culmination of all of these things that are impacting reimbursement or practice, it is significant, and it's not lessening. It's getting greater and greater. So we thought that might be helpful. And the next slide hopefully reminds us that we have made impacts with advocacy. And as Mark said, from a therapy cap perspective, we could probably have an argument as to whether or not we actually won on that or not. But we have created situations where we've been listened to, and it has changed CMS's mind or track, if you will. And if you read the proposed rule, as Mark said, 700 and some pages are the history of, even just reading specific to the assistant reduction, you can see the iterations that we've gone through in the last few years with that policy. Again, such that it was, going to be by total treatment time, and then it was by service, and then it was by unit. And so we've made progress. There's TRICARE and the use of assistance in care delivery, the E&M codes last year, the application, as I said, of the de minimis policy, the PDPM parity adjustment. We may have kicked the can down the road 1 year, and sometimes that's, a success. But advocacy absolutely does work. So as we look at what opportunities we have from an advocacy perspective, on the next slide, we talk about, and we tried to, throughout the presentation, kind of identify these opportunities specific to this proposed rule. So Mark talked about telehealth. So you've got two aspects of that, right? Adding us as eligible clinicians, as well as getting the therapy codes on the right list, right? Category 1 and 2, and not the one that's going to or set to expire. The therapy assistant payment reduction. Obviously, we are advocating at least a delay in that. We're looking at, possibly some exceptions as it relates to rural and underserved areas. The remote monitoring, the codes and the therapy use, CMS discovered that those are incident to codes. As Mark said, yeah, I like that, Mark.
It was an aha moment, right? Oh, look at there.
Above.
That's right. Look at there. It's an aha moment.
Oh, wonder how that happened. It's incident too. But those are the things that, that we need to catch, and we need to continue to bring to their attention. The inability for institutional providers to participate in MIPS. I mean, is that going to change? I mean, obviously that there would be a lot of work for that to change, but I think it's significant enough to continue to bring it to the forefront and to remind them, oh, and hey, by the way, remember 80% of the Part B providers don't have, access to MIPS. And then the rehab therapist in the health IT and information exchange. Again, just encouraging our disciplines to be at the table as it relates to incentives for exchange of health information and so on and so forth. And I think it's critical to remind us all, don't just depend on the entities such as Nara and APTA and AOTA and ASHA for their submission of comments. Individual comments are critical, and they hold a lot of weight. Go ahead, Mark.
Yeah, let me just, I've been involved with Nara for just about a little over a decade. And I know many of you have been involved much longer than that. And dealing with advocacy on the Hill and doing the, Hill days with the various disciplines and going to do Hill visits with Nara and whatnot. And I really feel like probably over the last 4 or 5 years, maybe a little less, the current generation of CMS folks that we get to interact with, I feel like are more responsive than when I started doing this, way back when. And so to Leanne's point, don't just rely on APTA, AOTA, ASHA, or NARA to be your voice. The more voices that are added to the chorus, the louder we get. And so while the large organizations can definitely handle the heavy lifting of putting together those long comment letters and how tedious they are and all of those things. You may have 3 or 4 bullet points that are extremely important to your organization. Make your own comments, send those in, add to the chorus, because the more we have, I think the more impact we will have at the end of the day. And I think they're more receptive now than they used to be. So.
Well, and the only thing I would add, Mark, as you were saying that is any examples of how this impacts the patients, right? Your personal examples, whether it's personal you yourself or within your organization or so on and so forth, but those are worth their weight in gold as it relates to, telling the message and I think critical to us.
For sure.
So
for sure. All right. Sabrina. Hey, look, Sabrina's back.
Hey,
I am back. Thank you so much, Leanne and Mark. That was a great presentation. You did a great job of really highlighting items that are officially, I think, clear as mud to a lot of us. I did, as chair of our Government Affairs Committee, I want to just echo what both of you were saying in regards to advocacy and add a little bit more information to that. Christy, if you go back to the last slide, I did want to highlight that we do have our Nara Advocacy Center. And if you log on to that, you will find great resources on there. As Mark pointed out, CMS has been more open to our comments, but I also feel like our advocacy to our legislators also has come a long way over the years, and they really are very receptive to what we have to say. So with that, I wanted to highlight the CMS comment letter is due on the 13th. That's also one of the reasons why we wanted to have this webinar today, really to give everybody enough time to digest those 800 pages, but then to review the content of today's webinar and really think about what you could put into a letter to CMS. It is really important also that we are advocating to all of our legislators, and those personal stories, as Leanne said, are so important. So anybody can advocate. I know we get that question a lot. Is it just management that can advocate or just an organization? And I love, Leanne, how you said, don't just rely on all the professional organizations, because at the end of the day, we are practitioners, all of us. And so we want to make sure that we are advocating for our patients, that we really are sharing those stories from the front line. How has telehealth helped us? How has it helped our patients? How has it helped access to care? But also with that, looking at and telling that story of why assistants are so important as well, and the value that the assistants bring in caring for our residents. So I just wanted to add that. Again, great presentation. I want to just highlight, and I'll answer a couple of questions that came in. But if you do have any questions for Mark and Leanne, or Leanne, who has now been labeled the angel from above, if you could put that into the Q&A and we will get to those. As Christy has highlighted here, our Nara Advocacy Center as well. The question was asked, were we recording today's webinar? Yes, just as a reminder, we were recording today's webinar. A link to the recording as well as the handouts will be emailed to all registered participants within 48 hours of the conclusion of our webinar today. We will also be putting it on our Nara member portal as well. Christy's highlighting it.
Christy, I'm unclear as to where we get to the Advocacy Center. Could you please make that?
Right.
That's awesome.
Trying to help. Just want to make sure everybody knows.
Thank you. Mark, people like your idea of having the flow sheet. I think that's a great idea. I think that the de minimis standard, it's, as you highlighted, one of those examples was difficult for us to understand. And so I think the question becomes really, what are your thoughts, both of you, on how do we educate the line staff therapist on really the de minimis standard or on the overall assistant payment reduction?
Oof. I was given a long pause to see if Leanne would answer.
Well, again, I think it's critical that we don't change, again, focused on 15 minutes and stopping at the clock. We have to deliver the care that our residents, patients need. And so, I think if you think about strategies as a therapist assistant duo, when you look at even though it's by service, it's by unit, if you will, I think we really need to focus on how we are care planning, how we are strategizing on interventions as the supervising therapist. What is it that I really need to accomplish when I get my hands on the patient and that sort of thing, and look at the interventions. I think we need to be very thoughtful in our approach as we schedule those supervisory visits and schedule the collaboration with the assistants, and again, just make the best use of the time that we have based on the licensure that you have. And so other than that, I think if you get too try to, what was the word, what's your word, Mark?
Strategery.
I
think that was W's word from back in the day.
Strategery. I think it's a slippery slope. So I think you have to go in eyes wide open.
I think for the operators, there's kind of two sides of this discussion. There's compliance side, and you have to be compliant and all of that. And there's an operator side. That's where the strategery comes in. And so if you have the opportunity to divert maybe your therapy assistants to other payers, right? If that's appropriate, if their skill level and specific skills are appropriate for the Part A patients that are on caseload, or the Aetna patients that are on caseload, right? Then maybe we can do some of that diversion to help mitigate the reduction in payment and use most of your therapist time on the Part B patient. That's one thing. The other thing that I've always advocated for wherever I've worked and whoever I've worked with is that you need to educate your team. They need to understand the payment changes that are happening. They need to understand how Part B gets paid for versus Part A gets paid for. And they need to understand that their clinical decisions have an impact on the bottom line. And I'm not saying that should drive their clinical decisions by any stretch, but they need to understand how that works. They need to understand how they get paid. And that'll help them be better strategic thinkers as they're planning for that treatment session with little Miss Smith.
Well, and I think in any scenario, nobody likes to be told what to do, right? So if you can have some conversations, if you haven't started already, and get feedback from, okay, what are your thoughts? Do you have any, maybe they can come to some of these realizations on their own in regards to the different payers and that sort of thing. The other thing is that you have to do the math, right? You have to look at yes, there's a reimbursement differential now, but what's the pay differential? And that's going to vary, geographically and so on and so forth. So, it's not an across the board, there's no one silver bullet. I think you've got to be creative in your approach.
So do you think it's also important, you both mentioned several times really, and I completely agree, the importance of not changing behavior in our billing and the concern of seeing an increase perhaps of the rounding to zeros and fives. So would you recommend, maybe starting now with some audits of billing just to see if there's been, some changes or variations within billing practices, to start that education now in preparation for this? We hope will not go through January, but the possibility of it going through in January, just preparing for those conversations.
Yeah, I mean, I would absolutely, again, these things happen and the CMS expects to see, us with a drastic response. So I think anything that we can do, as Mark said, you've got to educate the staff and they need to understand the why. We can't, have drastic changes in practice. So if they understand what's going on, what it impacts, how it impacts, and that we need to continue, some consistency with how we deliver our care, especially from a minutes perspective. I think that's absolutely, auditing is a great approach to that.
I think to Leanne's point, having your staff understand the why is extremely important. I guarantee you there will be we'll hear from some therapist or see on a Facebook post after this change happens that Medicare only allows us to bill at 15-minute unit. I guarantee you that's going to happen. And that's going to be somebody who worked for a company who didn't educate their therapist on the why we're having this conversation, and helping them understand that that we bill by 15-minute units, but you bill for what you did, and so understanding the why of what we're asking folks to do is always very important. Go ahead.
And Mark, you reiterated it several times when you were talking about it. Those remaining minutes, it's not that they're not relevant or not billed per se. I mean, they still need to be there. They still need to be documented. They still need to be supported, and so on and so forth. And so, again, you don't want anybody feeling like their time is being negated. Those minutes, you still only have as many units as you have based on the total timed. So.
Agree.
Again.
Well, thank you so much, Leanne and Mark. We really appreciate you both doing this presentation today. It was great. Remind everybody to advocate and to get your comments into CMS by September 13th. And with that, thank you, everybody, and have a great day.
Thanks, guys.
Thanks so much.
Have a good one.